So good evening or good morning or good afternoon. So depending from where you are joining us tonight to attend the first Migraine Multidisciplinary Summit. It's one of a kind educational activity, and during which we'll be hosting headache care providers from different disciplines in order to learn about the multidisciplinary management of migraine. The aim of this webinar series, and there will be three series of this webinar, is to highlight the need and the importance of establishing a multidisciplinary treatment program for the management of migraine, and to always encourage the intense interdisciplinary collaboration between nurses, pharmacists, physicians from different specialty for optimizing the care of migraine and giving our migraine patients the best comprehensive treatment. So first, I would like to start by thanking our sponsor for tonight, AbbVie. So thank you, AbbVie and the Migraine Medical Forum from the AbbVie Medical Affair Gulf Group for supporting this educational activity. And I would like to welcome our three headache experts today, Dr. Marlene Mukarzel, who will be representing the pharmacy profession, Mrs. Joelle Massouh, who will be representing the nursing profession, and last but not least, Dr. Kaleen Jaddam, who will be representing the neurologist profession. So let me start by introducing Dr. Marlene Mukarzel. Dr. Marlene Bijani Mukarzel graduated with a Doctor of Pharmacy degree from St. Joseph University, Beirut, Lebanon in 1994. She is double board certified as pharmacotherapy and as nutrition support. She is also certified practitioner in health quality. Dr. Marlene is currently the pharmacy manager at Sheikh Shakhbout Medical City, a joint venture between Sahha and Mayo Clinic and the largest tertiary hospital in the UAE. Dr. Marlene will speak today about the pharmacotherapy of migraine, and she will tell us about the pharmacology of the traditional treatment as well the new innovative treatments in migraine management. Thank you, Dr. Marlene, for accepting our invitation. Please, you can start your presentation. The floor is yours.
Good evening. Can you hear me well?
Yes, we can hear you and we can see your slides very well.
Yes, thank you. So good evening, good morning, as Maya said, for everyone. I'm here to talk about migraine and what the pharmacist should know. 1 second, I'm sorry. I cannot. I'm trying to. Okay, I'm sorry. Let me. Give me a second just to open my slides again.
Yeah, sure, doctor. So meanwhile, I will remind our attendees that this webinar is CME accredited by MUHAB, so they will receive a CME accredited certificate with the 2 CME credit within 1 week from today, and this certificate will be received by email. Also, please, if you have any questions for any of our attendees, try to write your questions in the Q&A session. I will do my best to address all your questions so we can benefit of the presence of the 3 experts with us tonight.
Sorry for that. This will stop other screen sharing. Yes, and then this one. Yeah, I hope this will work. Yes, thank you.
It's working.
Okay.
Perfect.
Fine. So I will not delay you more, and I'm going to talk about migraine in its preventive and abortive treatment. I have no disclosure. And last year, I asked the team, if I say migraine, what do you think of? And they gave me different answers, like propranolol, topiramate, and you have the list. Some of them said the CGRP inhibitors. This year, I asked the same question again, and I hoped that more of them will say these CGRP inhibitors, because this class of medication is in the market since more than 5 years. We talked a lot about it, but we need to talk more and more, to attend more seminars. I think people should read more about it. And I felt how much it's difficult to change what we learned already. Some people spoke about different kind of things that we can do in migraine prevention and treatment, and I think the next presentation will take you through that. So I want you, I hoped that it was not online, I would have asked you, but if you see this word like migraine, from a treatment point of view, medication point of view, yourself, maybe you can put on a paper, what do you think? What is the medications that comes first to your mind? And I hope that after this presentation, I would have changed a little bit from this knowledge, or helped you to know more about migraine prevention and treatment. And why I'm talking about that, this person, I'm not sure if you know him. His name is Alvin Toffler. He wrote a book called Future Shock. And in this book he wrote, the illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn, unlearn, and relearn. I thought about that again when I was thinking about the new class of medication used in migraine in general, which are the CGRP antagonists. And when I felt that the information did not reach many of the pharmacists, I asked a few pharmacists around, and I felt that they are not really, they don't know about it. And this is in the market since 5 years. So I like this photo, and I kept the one that wrote it. So we learn, we unlearn, and we relearn. Today, I don't want you to unlearn everything you knew about migraine and the classes. I will talk about all the classes, but I want you to learn something new. And every year there is something new. Today, I learned something new about the migraine treatment, and I will let you know at the end of this presentation what was it. I'm not a neurologist nor a neurology clinical pharmacist. I worked some time in the ICU as a clinical pharmacist, but I'm surrounded with people with migraine, my daughter, my sister, my friend. And I think most of us have at least 2 to 3 persons with migraine around them. So the topic is interesting, even if we are in a community pharmacy and we do not deal a lot with migraine patients, but definitely around us, we have patients with migraine. Those are my objectives. And the approaches to treat migraine or to deal with migraine are 3. The first one will be discussed a lot with Joël in the next presentation. Then either we give symptomatic relief for the attacks, or in some cases we can give prevention for the migraine symptoms. What are the treatment for the symptomatic treatment for migraine? We all know the paracetamol and the aspirin, the non-steroidal anti-inflammatory drugs. And many people, when we say migraine and how do you treat migraines, they will say triptans. And I'm here to emphasize about the side effects, the contraindications, the the people who can use triptans but not be relieved by using the triptans. And we have the other classes, the ergotamines that we know very well. The new information that I'm not sure if everyone knows about is a new medication called lasmiditan that is also working on the 5-HT1, like the triptans, but not on B and D, on F. And this makes it with having less side effects than the triptans and less contraindications. And the group that I want to talk more about today is the CGRP antagonist. In this slide, I'm talking about abortive treatment, but CGRP antagonists can be used for prevention and for symptomatic treatment, and it depends on the molecule. Either you will use it here or there. Now, as I said, we all know that there are contraindications for triptans. We also know that there are non-responders. 40% of the attacks will not be relieved by a triptan in some patients. And that's why we sometimes change the triptan. Instead of the oral, we give them intranasal. We tell the patient to give a higher dose. And sometimes the patient will start to use it more and more, which will cause medication overuse headache. Now, what are the new medications? As I said, 5-HT1F receptor agonist and CGRP receptor antagonists, which are rimegepant, ubrogepant, and zavegepant, and this is for abortive treatment. That's the one that I talked about. The dose is 50 to 100 milligram as a single dose and not to be repeated. This medication is already available in UAE. The dose should not be repeated, but in the next attack, the patient can take with the next attack a higher dose. That's one of the counseling tips. If you have this medication in your pharmacy, that's one of the counseling tips that you can give to your patients. Now, again, going back to the recommendations related to how we treat migraine episodes, give triptans, give NSAIDs. It is not indicated to give opioids in migraine attacks, and as you will see in the next slide, they are still given. And there are other recommendations, and this is very important. Triptans should not be used more than 9 days per month. And when you give combination, not more than 10 days per month. And also the simple analgesics should not be used more than 15 days per month. And that's where I told you that how we use our medications for migraine, and opioids that are not recommended are still used in migraine attack. So that's a repetition, but I put it here because in the third one, you can see MOH. So what is MOH? I just mentioned it, but if you see it just like that, you see MOH, I think the first thing we think about is the Ministry of Health. But when we talk about migraine, MOH is medication overuse headache. So there is a risk of medication overuse headache for patients with migraine and when they use triptans. This is important because with the new class, the anti-CGRPs, there is no risk of medication overuse headache because the mechanism of action is different. So there are also comorbidities. The patient with migraine may have comorbidities, and this is important to know when we are dealing with those patients. Now, if the patient is having a lot of attacks, frequent and long-lasting attacks, if they are causing disabilities, if there are contraindications of those acute therapies, we decide to give prevention for migraine. And there are different recommendations, number of headaches, and there are experts' opinions also on when to start prevention. There is, the definition is not very strict, and it's up to the neurologist to decide if he will start prevention or not. As I said, the neurologist will decide, and I will let you know what is the role of the pharmacist. The pharmacist should explain to the patient when he took this prevention, what will happen to him? Will his migraine disappear? And the answer is no. So the migraine prevention will reduce the attack frequency, severity, and duration, but it will not stop everything, all the attacks. It will also improve the responsiveness to the treatment of acute attacks. So they will feel better after taking their acute medications, and definitely it will improve their function and reduce their disability. And it will also prevent the progression from the episodic to the chronic migraine. So my first take-home message for today is that migraine prevention will not stop the episodes. Maybe they will have the same frequency, but less intensity, and in many cases, the attacks will be less frequent. And pharmacist's role is to set the expectation of the patient. Now, another point, and very important point to know, except the CGRP antagonist, that is my focus today, all the other medications that definitely comes to your mind when you speak about migraine, all those medications were not studied. Like when they started to be used, it was not to be used in migraine. They have many different indications, like the anti-epileptics, the antidepressants, the beta blockers, etc. The other information is that many of them are off-label use in migraine prevention. And you will see in the coming slides, in green, it means the medication is labeled for migraine prevention. And when it is not green, it means we are using it, like the metoprolol, for example, but it is not labeled for this migraine prevention use. So what do we use? Depending on the other indication of that medication, we choose the medication, and the choice, we know that it is the physician, he will do the choice. And I wrote here what are the medications that we may use. And as I said, when you see them in green, it means they are the medications that are labeled for migraine prevention. And here comes the CGRP antagonists, and that are injectables or oral medications for migraine prevention. So what do we choose? And again, this slide is summarizing what do we use in which case. My take-home message here is many of the migraine prevention medications are not labeled, as we said. When we counsel the patient, we need to tell him that, for example, I'm giving you topiramate for your migraine prevention, and do not mix up and tell him that I'm giving you your topiramate, it's for epilepsy, because we are used that topiramate is for epilepsy. This is important, and it happens in practice. Sometimes you give an information for the patient, for example, about propranolol. You tell him that this is for your heart, this is for your tachycardia. And then the patient is taking it for migraine, and it may confuse the patient. So it's very important how we counsel the patient and what we tell him. And again, the anti-CGRPs were studied only in the case, in the patient with migraine. Again, all those medications, they have side effects, as we all know, and they may be contraindicated in our migraine patients. This is a chart on how the physician will choose. He will go to one medication, he will wait for 6 months, and then if it did not work, he will change the medication. And that's how earlier we were doing the migraine prevention. And now we have the new era of those anti-CGRPs. An important information is that sometimes the migraine will improve by itself. I told you that my sister have migraine, and when she married, she got better. So in 10% of cases, the migraine will improve independent of the treatment. Now, there are principles for prevention. We start at low doses, we increase. Then, as I said, we give it 6 months. We avoid the overuse of acute headache therapies. Definitely, we don't use opioids. And also, we make sure that the medications, we take care if the patient is a female with childbearing potential. There are always a question about pregnancy, and I have added a few slides at the end related to pregnancy. Again, the same principles that I already mentioned. And so when do we use this new group of medications? When there is no response, they have a good benefit. It's an early benefit. And they have different routes. They have injectable routes and they have oral routes. What are the disadvantages? Definitely, they are higher cost than the old therapies. And sometimes, like, we do not have insurance approvals and they are expensive for the patient. A quick story. I attended a presentation from a neurologist, and he said that when he was a resident, like long time back, they injected them CGRPs, something that will affect the CGRP. And he said that he had the worst headache in his life. And he was telling that the Neurology Society were waiting for this group of medication because they knew very well that this group of medication will help them in treating their patient with migraine. So what this CGRP will do, it is really like, it causes the vasodilation that will cause the migraine attack. So if we block the CGRP, then we will have the effect that we need in migraine treatment and prevention. So what are those items? They are mainly monoclonal antibodies, and the monoclonal antibodies are the ones that are given sub-Q or IV, and I will go to them in details. But also there are small molecules, and those small molecules are called gepants. Some of them, the small molecules, are used for prevention only. Some of them are used for prevention and treatment. And some of them are used only for treatment, like the ubrogepant. And the new one, as I said, there was a new information for me today, the zavegepant that was newly approved in the US, and it is an intranasal CGRP medication. Those are the injectable forms. Some of them are sub-Q and some of them are IV. Because here I'm trying to answer the question, are all anti-CGRPs the same? So we said that in migraine, we want to think CGRPs, but there are many CGRPs now. There are about 10 of them. And are they all the same? And we will answer this question at the end of this presentation. So those are the injectable ones. And they are definitely studied in chronic migraine, and they all work on the receptor and on the peptide. Definitely they target the receptor. So erinumab is subcutaneous, and it is taken monthly, either 70 or 140 milligram. Frimazezumab is also sub-Q. One of them only is IV. I think this is the last one, the eptinezumab, and it is given Q3 months intravenously. And you know, it depends on the patient. Some patients, they like to take every 3 months. The IV, definitely they will take it. So the doctor is, is sure that the patient took his medications. The sub-Q, sometimes we're worried about the compliance. So there are some advantages on the IV over the sub-Q medications. They have some side effects. They are not all the same. Constipation is a very known now side effect of ianalumab. And also, for example, for iptinizumab, there is dizziness and nausea as side effects. They were all very well studied. They have studies in migraine prevention, and it's only in prevention that we use those medications. Now, the new mechanism of action, the new ones that are called gepant, those are not biologics. They are small molecules, but they target the same, they target the CGRP receptor. The one that is called rimigepant, it's used either for prevention or for treatment. It has few side effects. Another one is atogepant that is used only for prevention of migraine, and it has 3 strengths, 10, 30, and 60. And those are the adverse effects. Now, these two, the ubrogepant that I think will be discussed at the end of this session, and zavegepant is the one that is very new. And as I said, I learned today about it, so I wanted to add it to my presentation. It's not yet available in UAE and in the Gulf countries. It was only approved in March 2023, and it is a new form, like it's intranasal, and it's given as a single dose, and it has some side effects. But the ubrogepant is a small molecule, as we said. It's oral. It's given 50 to 100 milligram as a single dose, and that's a very important counseling tips for pharmacists. If after 2 hours the patient is still in pain, the patient can take another 100 milligram after 2 hours. So the maximum dose of ubrogepant that I did not mention here is 200 milligram per day. And I was asking myself, what is the maximum dose per month, for example? Because we said, for example, triptans can be given only 9 times per month. So what about ubrogepant? I just asked this question, and it was studied for around 2 months with a dose of 200 milligram every other day, and it can be given. So if the patient has many episodes of migraine, they can still take it 100 milligram daily. But this is for abortive treatment, so I don't think patients will have migraine daily for the months. But the maximum dose per day is 200 milligram. Now the side effects are nausea in 4%, xerotomia, and drowsiness and fatigue. Many times when we speak about migraine, we are asked about the pregnancy. The anti-CGRPs are contraindicated in pregnancies. When they are given for prevention, they should stop taking them early if they want to get pregnant. There are a lot of advice that we can give a lady that is pregnant and if she has migraine, and I think the next presentation will help you over that. So what we give paracetamol, metoclopramide. We avoid NSAID in the first trimester, and for prophylaxis, nothing is totally safe, and we give some supplements. And sometimes with pregnancy, migraine attacks are much less, because sometimes migraine is related to the hormonal changes. So we cannot offer a lot of choices in pregnancy. So my third take-home message is that preventive treatment of migraine in pregnant patients should be avoided, and anti-CGRPs are contraindicated in pregnancy and should be discontinued 5 months before attempting to be pregnant. So that's the question. Are all CGRP the same? Antagonists the same? No, they are not. They have different routes: subcutaneous, IV, oral, or intranasal. They can be given daily, every other day, monthly, or every 3 months. So, I mean, they are totally different. It's not right. I wrote all used for migraine prevention. That's I should change this. Most of them are used for migraine prevention. Some are used for both prevention and abortive treatment, but the 2 ones that are in bold are only used for abortive treatments, the ubrogepant and the zavegepant. And they have a different side effect profile, definitely. So now I am putting the same slide again. So for you, if now I say migraine, what do you think of? And I hope that this, the answers that you wrote at the beginning of the presentation is different now. And thank you.
Thank you, Dr. Marlene, for an excellent and very comprehensive presentation where you discussed all the treatment options for migraine, whether the old ones that has a lot of side effect profile. And usually we had really an unmet need in the management of the migraine before this era of anti-CGRP treatment that are more effective, if we can say, and better tolerated in our patient than the old therapies. Please allow me to take a few questions before you leave us. So I would like to ask all our attendees to take advantage from the presence of Dr. Mukarzel with us and write their questions in the Q&A box. One question for you, glucose, does glucose or sugar intake reduce or affect headache? Do you have any insight into this?
I mean, from the readings I have done, this was not mentioned. Maybe Maya, you are the expert also. I don't know if you have any other information, but for me, no. If a short answer is no, but
no, actually, no, there is no evidence-based data about the sugar intake for migraine. So another question, do we have cost-effectiveness studies that compare the cost-effectiveness of all these drugs in migraine? For example, cost-effectiveness of all therapies compared to the anti-CGRP, or even cost-effectiveness study between those anti-CGRPs?
Between them, there is no, as much as my knowledge. For each individual ones, they have done cost effectiveness study, and where they take even the indirect cost of, for example, a patient not going to work because he has migraine, and now you start the preventive treatment and he has less episodes, so they are cost effective, and that's why they were approved. And even they are approved, for example, by NICE, by the UK. Here we added them to our formularies because they are really cost effective, even if they are more expensive than the normal therapy. And as I said, what's very important is that they are studied for migraine. I mean, all the other classes were not, done for migraine prevention or treatment. You are on mute, Maya.
Excuse me. So do we use the triptans for migraine prevention, and is vomiting a common side effect with the triptans use?
Triptans are not used for prevention. Triptans are used as soon as you have an attack or just before, like the patients, they will feel it, so they will take triptans. And as we said, like they have to take a good dose. Now, the vomiting is associated with migraine, not with triptans use. So if patients, they have vomiting, nausea and vomiting with their headache, then the recommendation is to take like metoclopramide, for example. And that's why the intranasal forms of migraine abortive treatment are done, and triptans there are some triptans in intranasal form, and as I said, now the anti-CGRPs will be coming with an intranasal form because migraine comes many times with the nausea and vomiting.
Another question, do you think that, or when zavegepant will become commonly available in most of the countries, whether in our Middle East region or other countries? And do you think that due to its side effect profiles, its approval will be delayed in some countries?
Honestly, I don't think the side effect profile will affect it. It's always like a strategy that the companies they do if they want to market the medication in a country or another country. Usually in the Gulf region, those days we're lucky to many of the medications, not only migraine medications, but many of the medications are approved. As soon as they are approved by the FDA and marketed in US, the second country will be either UAE or Saudi Arabia. I don't have real information for now. As I said, while I was updating my slide for today's presentation, I read about the new medication, and I wanted to mention it for all of you, so you can start to learn about it. But I don't have any information when it would be marketed in our region.
So it was approved around March 2023.
March 2023.
Yeah, so we expect like to be available, especially as you mentioned in the Gulf region, within 1 year from the FDA approval. So probably around next spring. Another questions and interesting one: are you aware about any drug-drug interaction between anti-CGRPs and warfarin drug?
Honestly, I didn't go through the drug-drug interaction profile of all of them. So I don't want to give the information without checking it. It will be easily found in any of the references, but I did not read that they are interacting with warfarin.
So I would take
I would have to check it and maybe put it in the Q&A answer.
Yeah.
Later.
But I will answer on your behalf as a colleague. So because I had one day a patient who was taking anti-CGRP and was a stroke patient, and he was on warfarin. So I checked this, and actually, no, there is no drug-drug interaction between warfarin or acinocumarol and anti-CGRPs. They can use if a patient is on anticoagulation, he can safely use anti-CGRP, and this is one of the main advantage of this new class of drug. So another question about the
next presentation, Maya.
Yeah, thank you.
When I have questions, I usually add. Thank you, Maya. I mean, yes, you are the expert and you work in a neurology clinic. So, I mean, definitely you have patients. So thank you for that. See, the experience speaks.
Another question: what about the administration of anti-CGRP? Is it recommended to be administered in a particular time of the day, or it can be administered anytime? And does its administration related to food intake, so before meal or after meal?
Nothing about food. It can be administered anytime and not related to the food.
And a final question for you. So do you recommend any herbal supplement for migraine prevention in general and in pregnant women in particular, since most of the medication are contraindicated in pregnancy? So can, in your opinion, a woman take any herbal supplement for prevention of migraine? Although as pharmacists, we don't recommend any herbal product for pregnant women, because I would like to remind all our attendees that herbal supplements, most of them, they are not regulated by bodies like the FDA and EMEA, and those are not scientifically tested. So you can never know what is the exact ingredient of these herbal products.
You have your answer.
Yeah, but what about migraine? Are you aware of any herbal supplement that can prevent migraine?
No. I mean, as pharmacists, we have to be I know that when you work in a community pharmacy and you have all those products that you want to sell, maybe, but it's definitely not recommended, neither for migraine prevention or in pregnancy. And more in pregnancy, I would be much more worried, because we don't know what is in those medications, and we're not sure of anything. Like, they are not regulated, as Maya said. Thank you, Maya.
Yeah. So another question, you mentioned in your presentation that to avoid anti-CGRP 5 months before pregnancy or trying to get pregnant. Why? Are anti-CGRP teratogenic?
They are contraindicated in pregnancy. They started to have some registries, but we're not sure yet that it may be. We don't know. We don't say that they are teratogenic, but there is no enough data to say that they are safe.
And a final question for you: how do you see the role of pharmacists in this emerging number of therapies for migraine? So how would you define, or I would like from a pharmacist perspective to highlight the role of pharmacists in migraine management?
I will not speak about specifically the specialized pharmacists in neurology clinic like you, Maya, because they are very rare. I want to talk about the common, like a community pharmacy or a pharmacist working in a hospital. Our role with patients is mainly to explain for the patient, to counsel the patient. So the side effect profile of those medication is very important. I mean, my first message was set the expectation when you start a prevention. So explain for the patient, yes, we are giving you an injectable, but you will not be migraine free. So that's the first thing and explain the side effects. Yeah, I spoke about erinumab and constipation because it's really happening with many patients, and we need to tell them. And they may experience it, they may take something for prevention. Yeah. The side effects are clear, like you open a lexicon, you can find the percentage of the side effect, and when it is high, you need to mention it to the patient so they are clear about it. Explain very well the doses. Like, as I said, our new medication now, the 200 milligram daily is important, that because if the patient is not relieved, he can take another dose. So it's important to, when you have a new medication in your pharmacy, to read about it, take like the important counseling point, what you need to tell your patient, and give it to him. So that's our role. That's mainly our role. The doctor will prescribe, and our role will be to let the patient get the most, the best use of this medication.
So thank you, Dr. Kerzel. I have a question, I will answer it again, about the drug-drug interaction between anti-CGRPs and anti-epileptics, so epilepsy drugs. So if the patient has concomitant epilepsy and migraine, so it is safe actually to prescribe him anti-CGRP. Usually they are safe and we don't have interaction with most of the new anti-epileptic that we currently and frequently use in our epilepsy patient, except for clonazepam. So clonazepam might have some interaction with anti-CGRP, but also it's better to check and individualize the drug-drug interaction profile for each patient. So thank you, Dr. Mokerzel. So the take-home message from your final discussion is to personalized treatment for every patient and to set realistic expectation. And this is very important in managing chronic disease, especially the neurological one. So the drug will not be this magic drug that will cure your migraine forever, and discuss all the expected side effects to mainly avoid our patient go to Google and read from non-evidence based websites. So thank you, Dr. Marlene, for joining us despite your super long day and busy schedule. Thank you, and looking forward for a next talk from you. And with no further ado, I will move to our next speaker. So Mrs. Joelle Massouh. So beside that, she's my friend. Joelle is currently the clinical manager of the Neurology Institute and the MS Center at Harley Street Medical Center, Abu Dhabi, UAE. Previously, she was the nurse in charge at the AUB MC MS Center in Beirut for more than 10 years. Joelle is the first nurse and healthcare professional in the Middle East to be double certified as a multiple sclerosis certified nurse and a specialist. She's a member of the International Organization of Multiple Sclerosis Nurses, IOMSN, and she actually serves on the board as a board member, represented all nurses from the Middle East on the Multiple Sclerosis Nurses International Certification Board, which was established to develop a criteria for certification and recertification and administer the certification exam for multiple sclerosis nurses. Mrs. Massouh also, she's the nursing program coordinator for the Middle East North Africa Committee for the treatment and research in MS, and she's responsible for organizing the nursing session yearly at the Menactrums Congress with a mission of advancing the specialty of neurology and multiple sclerosis nursing in our region. Joelle will discuss today the non-pharmacological treatment of migraine, and I already have a lot of questions for you, and I received many questions for you regarding the non-pharmacological treatments of migraine, focusing on the cognitive behavioral therapy, which is a hot topic today in migraine management. You are always the most welcome, Joelle. The floor is yours.
Thank you. Thank you so much, Maya. So can you see my slides?
Yes, perfectly.
Perfect. Okay. So as Maya mentioned, and as Dr. Marlan already mentioned, to really complete the management of migraine, besides talking about all the pharmacology and the complex pharmacology, we also have to, we cannot miss talking about the non-pharmacological aspect or approaches to manage migraine. So this is what I will be aiming to tackle in my presentation next. So we know that migraine is a complex neurological disorder. And actually, besides MS, which is my subspecialty, migraine is also a huge part of the population of patients we see as well. As we know, headaches are very common disabling conditions, and migraine specifically is a common disabling condition as well. So we do know that a lot of people live with migraine and suffer from migraine. And specifically suffer daily with the management of migraine and how they can live despite having migraine. And so this is what we will aim to really discuss and help with as healthcare professionals today. So the International Headache Society requires that patients must have experienced at least 5 headache attacks, each lasting 4 to 72 hours, and the headache must have had at least 2 of the following characteristics. A unilateral location, and these are things we know and we see in our practice always, and these are the questions we ask our patients when we are trying to distinguish migraine from other headache disorders. So unilateral location, a pulsating or throbbing quality, moderate or severe pain intensity, and or aggravation by or causing avoidance of routine physical activity. Additionally, during the headache, our patients must have had at least one of the following symptoms. So our patients will have presented with nausea and or vomiting, photophobia, and phonophobia. Lastly, we have to really exclude that these features must have not been attributable to another disorder. So it cannot be explained by something else or a better explanation. So migraine comes with a huge burden on our patients. It's a headache disorder that impacts a big number of people. Numbers-wise, approximately in the US, it impacts around 36 million Americans. It is more common in our female patients, 17% versus 6%. It's also more common in young people between the age of 30 and 39. And it's one of the most common causes of disability. So it's second ranked after low back pain worldwide among diseases with respect to years of life lived with disability. So imagine the burden of migraine for people presenting to doctors, to healthcare professionals, to providers of care. Now, what is the ideal migraine treatment plan? What do we really aim for as healthcare professionals, as physicians, as providers, as pharmacists, as nurses and clinical nurse specialists? We aim for a personalized treatment plan we aim to have this plan based on a shared decision-making model between the patient and the provider, because this is how we reach a successful and an ideal treatment plan with our patients. Because treatments, drugs do not work unless it's in patients who are taking them successfully and adhering to them. And also, any kind of education or approaches we give to our patients do not work unless the patients are convinced and we are all one team working with our patients. So let's start with, after the first presentation by Dr. Mardan tackled all of those pharmacological issues that we use in our daily practice, and we can say that we have reached a stage where we have very highly efficacious treatments for migraine, including all of the CGRPs. Now we have in our armamentarium of medication, all the CGRPs, and of course, all the traditional also migraine treatments that still work. And as a person living with migraine myself, I'm very thankful to all of the options that we have to use as pharmacology, but also it's very important to also think of the non-pharmacological approaches. So we teach our patients to do a lot of things, including many of the steps I will go through. So it's very important to tell our patients to maintain a diary of events. So if we want our patients to present to their next follow-up visit and they have no idea how many headaches they've had since their last visit, what kind of headaches they've had, it will be very difficult to really give them any improvement on the kind of medication they're taking, to really give them some better symptomatic care, to know if they have failed or responded to the treatment that they have been on. So it's important to maintain diaries. This is an example of a diary from the, things are available online anywhere, but this is from the Association of Migraine Disorders. Of course, we are in the era of tech, of apps. Patients have access on their phones to all kinds of applications. As healthcare providers from all kinds of disciplines, we can provide our patients with access to that. So a good example of a diary would include the timings of events. So, the day the event happened, the timings the event happened, the impact and the severity of the event, it can include the intensity of the pain as well, and the associated symptoms from headache, nausea, vomiting, all kinds of symptoms, dizziness, and whether the patients use rescue medications and how they responded to them. Now, the next thing would be to avoid triggers. So the concept of trigger avoidance. Of course, food comes up as a concept heavily in discussions with patients. It can be a valuable treatment for people living with migraine. Fewer than 30% of people with migraine have their symptoms triggered by food. Now, to be considered a migraine trigger, the food must trigger these migraine-related symptoms within 24 hours of the time it's consumed, and it must do so for the patient more than half of the time that the food is eaten to be considered a trigger for this patient. Now, I know it's a busy slide, but most of you know these and have dealt with this with your patients as well. So these are the common food triggers known for migraine, divided into classes, let's say. So for alcohol, particularly, we tell our patients to avoid fermented liquors, specifically red wine, which contains substances known as tyramine, tea, chocolate, and other substances. We talked about tyramine specifically found in red wine, but also found in substances such as HCG that our patients are going to smoke. Nice day. Caffeine, this is a controversial trigger always, because caffeine can be a trigger for some people with migraine, and it can also be a relief for others. So that is also an issue for certain people. We have to really discuss that with our patients and see whether this is a trigger for them or not. And lastly, phenylalanine containing foods and beverages such as nuts, seeds, and avocados, dried fruits, and aspartame containing food or even drinks like diet sodas. Also, from the concept of trigger avoidance, we have to avoid stimuli such as bright or flickering lights, because we know that can trigger our patient's symptoms. Also, excessive or repetitive noises, odors, fragrances, and even things like tobacco smoke and high altitudes can trigger our patient's symptoms as well. Our patients also can be affected by other triggers such as stress, simple things like illness, family issues, jet lag, fasting. We know someone was asking about glucose before and that question, but I would say let's focus more on the issue of hunger. We tell our patients not to avoid meals, not to skip meals. The issue of fasting. We know the concept of intermittent fasting is very popular right now. So for patients with migraine, that might not be a very good idea, because skipping a lot of meals or going prolonged hours, time-restricted feeding, and all those options of intermittent fasting, going many hours without food, might trigger a migraine attack. Abnormal sleep habits. Sleep is very important. All of those, they might generate stress. They might cause our patients to get a migraine attack as well. Exercise. Exercise comes up really if you want to give your patients of all kinds of diseases, whether it's MS or migraine or anything, the best tip or the best really advice you can ever give them is to tell them to exercise. If you can change anything behaviorally about your patients as healthcare providers, if you can get them to exercise, you'd be doing them the biggest favor in their lives. Specifically for migraine, we have to really get a balance, okay? Intense or sudden exercise can initiate headache in certain people with migraine, but in general, routine, moderate exercise has been shown to reduce the frequency of headaches. So we have to really gauge that. Engaging in regular exercise has shown promise in migraine prevention by improving health and reducing stress. Also, weight reduction. There are studies that have been shown to associate weight reduction and decrease in headaches and migraines. So it's important to find an exercise routine that suits our patients' individual preferences and does not trigger the migraines. So we also come to the concept of individualized and personalized approach with our patients. And here, after talking about all those concepts specifically, we will go into one of the most effective non-pharmacological approaches we can use to really assist our patients. And this is CBT, the concept of cognitive behavioral therapies. So what is CBT really? It's not technically one single intervention. It's instead a multidimensional approach that we can use to modify all those unhelpful and maladaptive thoughts, beliefs, and behaviors that are affecting our patients' response and to the chronic pain they are dealing with and to their migraine. It really complements the current migraine plan that our patients are following, that we are implementing with our patients. And the aim is to reduce frequency and severity of the current migraine attacks. Now, CBT is old. It's been there for more than 40 years, started originally by Dr. Aaron Beck. And the main tenet or concept of tenet behind CBT is how we perceive events in our life. It can affect how we respond emotionally, but more importantly, it can affect how we respond physically and behaviorally. So CBT helps people look at thoughts that may not be helpful to them and then challenge or restructure these thoughts so that they become more helpful. And the main change agent is that these thoughts, they lead to a more helpful and adaptive coping behavior. So our behavior becomes more adaptive to us. Initially, CBT was known to be applied only to depression, anxiety, the mental health issues. And then application started in diseases such as obesity, chronic pain condition, and then headache and diabetes as well. Now, what specifically is CBT? It's, as we said, goal-oriented therapeutic approach that focuses on alternating these negative thought patterns, emotions, and behaviors. What are the goals? We want to reduce stress and anxiety, alter the pain perception, enhance coping mechanism, also identify the triggers for the pain and the headache, promote healthy lifestyle changes. So even the approaches and concepts we talked about before, including exercise and food and diet, we want to really promote them through CBT and empower our patients. And it serves as a valuable complement to the acute and preventive treatments that we talked about in the first presentation. Now, this is to note here that individuals from underrepresented backgrounds or people with socioeconomic challenges, they face disparities in healthcare. This might really stand between them and not allow them to get a well-rounded treatment. It might impact their ability to participate in non-pharmacologic therapies because they might have difficulty, socioeconomic challenges from accessing expensive therapies, maybe like CBT sometimes. Although medications can be helpful in managing migraines, they often come with potential side effects like we discussed. And they don't always address the underlying psychological or behavioral factors that have contributed to the condition. So here we are kind of addressing the root problem. So non-pharmacological mind-body therapies such as CBT, on the other hand, they have very few side effects and we can use them concurrently with the medications. So let's look at the advantages really. Now, what are the treatment components of CBT? They go into technically these 5 classes. So education, cognitive restructuring, relaxation, behavioral activation, and lifestyle changes. And I will go into each one of these concepts as we go. So in education, how do CBT specialists or practitioners really go into these points with patients? They identify factors that can open and close what we call pain gates or thresholds of pain with their patients. So they give patients a sense of control over their symptoms. They build insights. So they educate their patients. A lot of patients, they want to understand the pain biology behind migraines. So they want to understand the difference between migraine and a regular headache. This improves behavioral outcomes. It also decreases catastrophic thinking related to pain. And it leads to reduction in pain and activity-related fear. Now, one of the main important tenets of CBT is what is called cognitive restructuring. And this is a collaborative tool that focuses on teaching people to identify and replace what we have identified before as maladaptive thoughts and thought patterns related to pain with healthier forms of thinking. And this is a shift in perspective that is achieved through restructuring negative pain-related thoughts and adaptation and adoption of a thinking strategy that is more balanced, rational, and realistic. And here, patients undergoing CBT treatment actually demonstrated greater brain activation in frontal regions involved in the cognitive regulation of pain, leading to improved top-down pain control. And CBT was associated with changes in gray matter in the dorsolateral prefrontal cortex, an area in the brain believed to be involved in pain modulation. What CBT specialists use with patients here is what we call a thought record. And it's a common tool that is used in the treatment of episodic migraine. It has a positive impact on beliefs, anxieties, and behaviors. And what it does is it examines pain-related cognitive distortions. So the patients actually have wrong beliefs and cognitive distortions. Common examples of these negative thoughts will include patients will be telling themselves these negative thoughts like, I can't handle this pain, this migraine will never go away, I feel useless when I have a migraine. Once these specific negative thoughts are identified between the therapist and the patient, the thought record will be immediately utilized. So it's a logical procedure. It modifies these self-defeating thoughts. These are self-destructive thoughts by the patient. And what the therapist will advise the patient is to use thinking styles that are flexible, compassionate, and healthy. For example, this self-destructive thought, like I can't handle this pain, it can be reframed through cognitive structuring, they are taught to reframe it as, although my pain is bad today, I have coped with pain like this before, and I can do it again. So using this flexible and compassionate approach to pain, it can help migraine patients improve emotional control and reduce pain severity. So it didn't just alter the thought, it will also alter the behavior and the pattern of the behavior as well. Now, moving on from cognitive restructuring, there's also the relaxation aspect of CBT as well. So the autonomic nervous system is thought to play a significant role in migraine. And the altered autonomic nervous system tone can be found from the initial phase of the migraine through the post-drone phases as well. So there are also techniques used by the CBT therapist, as well as thermal biofeedback, combined with relaxation training and EMG biofeedback, and they have demonstrated grade A evidence for their effectiveness in the prevention of migraine. It involves typically relaxation training, learning about the relaxation response, and strategies for inducing relaxation, including concepts known as progressive muscle relaxation, mental imagery, cue-controlled relaxation. And these can be taught to the patients, such as meditation or passive relaxation. There are also concepts known as mindfulness-based cognitive therapy for migraine specifically. And these are given through sessions taught to the patient. Furthermore, treatments like yoga have been really found to reduce migraine symptoms as well. And these are found, everywhere, accessible to patients. They can also be very helpful strategies too. Now, behavioral activation and fear exposure also help to discontinue the cycle of fear avoidance through inducing the feared activity. Here, CBT practitioners can systematically help people disengage from patterns of avoidance, often leading to a quicker return to baseline functioning. So this is a graded exposure. They use behavioral experiments to disprove these exaggerated fears that the patients have. So the person will move from the least threatening situation to the most feared objective. It is often the case that patients increase their exposure to events and activities that they once feared to tolerate more activity than previously believed. And then we move to the really more practical elements, which are the lifestyle changes. Here, for example, it is common that migraine sufferers might skip meals, they might become sedentary, they experience sleep disruption. All of these, they lead to increase in migraine disability. Therefore, the patient, through the comprehensive therapy, is introduced to lifestyle changes as part of this overall treatment plan by their healthcare providers and by referral to specific therapists as well, to practitioners. The clinician maintains an emphasis on the headache threshold rather than one specific trigger to pain. And of course, this comprehensive approach, it will really increase the ownership of the migraine control. Whenever we put the ownership back to the patient, it's better, it increases their autonomy of their condition as well. Of course, when they are suffering from insomnia as well, CBT specifically for insomnia, which is CBTI, is also very helpful, and it's been shown to be a first-line non-pharmacological treatment that is very effective in treating insomnia as well. Now, what are the opportunities and potentials for CBT use? It can be tailored to each patient's triggers, symptoms, and personal factors, as opposed to pharmacology. So medications cannot always be, tailored. Yes, we can increase doses based on patients' response, but in general, CBT can be more unique and individualized. And in medicine, we like to be more personalized, and this is the future of medicine, to have really personalized medicine. So in CBT, you are able to do that more. It's, easily accessible to be done online, using online and virtual reality. And due to the rise of telemedicine post-pandemic, of course, and this new reality, future research can focus on the efficacy of online-based treatments, virtual reality type devices to help patients respond better. It can introduce migraine triggers such as light or noise in a safe and virtual environment to lead to desensitization, such as the concepts we mentioned before, the fear and the avoidance, and to try to use desensitization in a virtual reality method. And this will help reduce frequency of migraines. So we can use VR and virtual reality to help patients decrease these fears from those migraine triggers as well. Also, other opportunities, patients with migraine, we know that they can feel alone and misunderstood because it's thought that migraine is a simple condition, it's just a headache, but we know that migraine is much more than just a headache. It's a chronic and disabling condition. And this is why people around migraine sufferers may not understand the depth or the disability of the condition they are living with. So group CBT can really be a safe setting for patients to gain critical social support. So we also encourage group therapy and group CBT, and it's also a cost-effective solution for patients, for clinics as well. So this might be an option and a potential for CBT use as well. Preventive as well, future research can focus on testing the preventive measure of CBT for groups that are vulnerable to developing migraine and progressing from an episodic to a chronic migraine. And this is how we can put a stop for this progression from episodic to chronic migraine. So the usages of CBT are really, they are limitless, and the potential for using CBT is a lot. So with this slide, I will end. These are my references, and thank you for listening.
Thank you, Joelle, for an amazing presentation. I have two quick questions for you before moving to our third expert, Dr. Colleen, who is waiting for her lecture. So the first question, would you recommend CBT to be done in addition to the pharmacological treatment of migraine, or do we usually stop the treatment, the medications, and start cognitive behavioral therapies?
Yes, it's usually part of a comprehensive treatment plan, because we really have highly efficacious treatments for migraine now. And it's not accepted to have people suffering from migraine in this day and age when we have really highly efficacious treatments. So it should be part of a comprehensive management strategy.
And a second question, as you know, in our Middle East region and among our Middle Eastern culture, we have difficulties to convince our patients to go visit psychologists who usually do these cognitive behavioral therapy and group CBT. So from as a nurse specialized in the field of neurology, and I know that you see migraine patients on daily basis. So how would you convince a migraine patient to go to visit a psychologist and perform cognitive behavioral therapies?
Yeah, actually, I mean, surprisingly, the taboo around these issues is really decreasing, and we are surprised by this. So what we really emphasize always is the concept of, mental health, and really discussing this, that this is not a taboo anymore. And we're not only referring you to someone dealing with mental illness. It's part of a mental health wellness and increasing mental health, and to really optimize your treatment plan. And this is someone who deals with migraine, people living with migraine anyways, and it will optimize your treatment plan. So we're really surprised by people's willingness to really see specialists. And in general, in the future as well, besides psychologists, other practitioners who are trained in CBT are also able to perform CBT and engage in CBT as well. And this is what they do in the US as well. Practitioners who are experienced in CBT are able to perform CBT as well.
So thank you, Joelle, for an excellent, again, presentation. So with no further delay, I would like to welcome Dr. Colleen Jabdam, our next and third speaker for tonight, and would like to apologize from her for this delay. So Dr. Colleen Jabdam is a consultant neurologist in MediClinic Airport Road Hospital. She graduated as a neurologist from the University of St. Joseph Joseph, Hôtel Dieu de France in Beirut in November 2014. She holds a subspecialty degree in critical care neurology from Paris 12, UPEC University, and a fellowship in critical care neurology from Pitié-Salpêtrière Hôtel Paris, France. She also completed training and fellowship in neurophysiology and epilepsy in Pitié-Salpêtrière Hospital and UPMC Sorbonne University, Paris, France. She had been practicing in Lebanon in various university hospitals as a consultant neurologist with special interest in critical care neurology, stroke, EEG, and epilepsy, and held an academic and teaching position as an assistant professor in Balamand University Faculty of Medicine. Dr. Kaleen will talk tonight about how to achieve better control over migraine attacks. Thank you, Dr. Kaleen, for accepting our invitation. The floor is yours.
Hi, everyone. I don't know if the screen is showing.
Yeah, the screen is showing and your sound is perfect. You can proceed.
Okay. I will need your colleague to start sharing slides with me, please.
Slides are already shared, yeah.
Okay, so I'm happy to join you today for this very interesting multidisciplinary meeting on migraine with all the interesting updates regarding various disciplines. So these are my disclosures I have prepared. So the first part of my slide would be a general rephrase of what my fellow speakers preceded in the preceding presentations. So why are we still talking about migraine? Because first, it is a highly prevalent disease. And when we say disease, we imply disability. So it's not just a headache, like many people would say when we call the office and tell them we won't be attending because of migraine, etc. So one would say, come on, it's just a headache. But it's not just a headache. It's a disease that causes high disability. And this is what we will discuss further on in the slides. And it's one of the most prevalent disease affecting almost 1.1 billion people globally, with a global prevalence of 14%. It's the sixth most prevalent medical condition worldwide. And unfortunately, it affects women much more frequently than men, with a ratio of 2 to 1. So usually we can say roughly that among 10 people, there is one affected by migraine. So imagine if there is tonight over 700 participants, we can count the migraineur or migraineurs amongst us. Concerning diagnosis, these are the ICHD criteria for migraine diagnosis. So it should be a headache that is usually unilateral, but this is not a mandatory condition. It should last from few hours up till 3 days, and in some patients it can last up to 5 days. It is a headache that should have 2 or more of the following symptoms: unilateral location, pulsating quality. It is of moderate to severe intensity, and it is aggravated by physical activity. And during this headache, we should also have 1 or more of the following symptoms, that is either nausea or vomiting, and photophobia and phonophobia. Photophobia being the disturbance and worsening of a headache due to bright lights, and phonophobia being the worsening of headaches due to loud sounds. And usually, as a rule of thumb, there is a high predictive value of the association of 3 symptoms, because sometimes the ICHD criteria is not fully met. So we can have an idea if it's really a migraine or not, with a highly predictive value of more than 95% if we have the 3 symptoms of photophobia, disability, and nausea. We categorize migraine usually into episodic and chronic migraine with a cutoff of 15 monthly migraine days, with episodic migraine having less than 15 monthly migraine days. And for chronic migraine, it would be 15 or more monthly migraine days. And if you can think of it, it's a part of your life. So it's half your month with migraine, it's half your life with migraine. So it's not just a headache. Concerning the pathophysiology and etiology, usually migraine can go through up to 4 phases, but these phases are not constant in all migraineurs. And they can sometimes be present in the same patient, or sometimes a patient can have 2 of them or only 1 of them. So, but roughly, we can have 4 phases in the migraine. The prodrome that is now an area of interest to us in the research of acute medications. Usually, a prodrome precedes the migraine headache by days, and it can have specific or non-specific symptoms of fatigue, drowsiness, yawning, impaired concentration, neck pain, water retention, photophobia, nausea, anorexia, etc., or food cravings. Sometimes food cravings are really specific for some patients. They say, I wake up, I open the cupboards and I start eating, and then I know that my migraine would hit 1 or 2 days later. And then there is the aura. As we all know, the migraine headache is mainly due to the activation of the trigeminovascular system. And usually this activation, when it is localized, it can be responsible of the aura. The aura is usually an alarm that would announce the upcoming migraine. It is a transient focal neurological symptoms, and usually it is a positive symptom, So it can be a visual aura, and usually the positive symptoms would be flashing lights, scintillation, what we call oscillopsy. It means the oscillating objects that we are visualizing. But sometimes it can consist of negative symptoms of scotoma, etc. But usually it is a positive visual symptoms. Also, the aura can be sensory with some numbness or paresthesia, or it can affect motor functions or language functions less frequently. So this aura usually and typically lasts for a few minutes, and then typically it should end before the onset of the subsequent migraine. And if we do not have this stereotyped succession of aura, then headache, then we should eliminate differential diagnosis, okay? And then we wouldn't be very sure or very easy diagnosing a migraine without further testing or brain imaging, etc. And then we move to our migraine headache with the ICHD criteria that we discussed previously. And then sometimes it is followed by a post-drome period of asthenia, of anorexia, somnolence, cognitive slowing, etc. So usually the majority of migraines, next slide please, the majority of migraines, the vast majority is episodic migraine, with around 10% of migraine cases being chronic migraine. And if we want to categorize episodic migraine further, we would speak of either low frequency or high frequency episodic migraine. And these categories also affect our treatment decisions. Low frequency episodic migraine being less than 8 monthly migraine days, and between 8 and 15, it would be the high frequency monthly migraine days. high-frequency episodic migraine. But this is not a clear-cut classification. So migraine is not destiny. We are never destined to be chronic migraineur or episodic migraineur. It's rather a spectrum. We can move back and forth according to treatment and management. So we have 8% of patients with episodic migraine transitioning to chronic migraine at least once per year. And usually these are the patients that are either non-treated or insufficiently treated, and vice versa. And good news for us, there are 73% of patients with chronic migraine that would meet the criteria of episodic migraine at least once per year. And there is a considerable proportion of chronic migraineur that, if treated optimally, would shift back to episodic migraine. So this is a disease that deserves high attention and evolving attention from us as clinicians, because as we said, it is a disease then causing disability, and it is a disease of high burden, be it on the socioeconomic level or on the public health level or on the personal, emotional level. So according to, concerning the treatment, there is also a treatment burden and highly unmet needs till now concerning the acute treatment of migraine. As we all know, the past 5 years have witnessed a high progress regarding the chronic treatment of migraine or the preventive treatment, but we still lacked optimal control of acute treatment, because we may have a lot of patients who walk into our clinics and on follow-ups, and then we would ask them, how have you been? Did you improve with the newly prescribed preventive medication, etc.? And then they would say, no, I did not improve. And this is the first response, and it would be shocking for us. And then if we go into details, we discover that they really improved, and that there was 50% decrease of their MMDs, or even 75% decrease in their MMD. But the remaining headache days are still disabling for them. And even if a patient shifts from 10 to 12 MMD until 3 to 4 MMD and is still missing her job or missing family occasions and lying in bed all day, she would say, I am not better, because these remaining headache days are not being well treated by acute medication. And this is where lies our high need for optimal and efficient acute medications. So as we said, there's the poor satisfaction with the current standard of care concerning the acute treatment of migraine. And I specify concerning the acute treatment. There's a high rate discontinuation of acute treatments for migraine attacks because of inefficacy or side effects, intolerability, etc., especially the side effects of triptans. There's a need for new acute treatments with improved benefit-risk profiles versus the current standard of care. And there is the low persistent and adherence to current standard of care. And especially there are some populations that are merely not covered by acute medications, and these are the high cardiovascular risk profile patients that would never be prescribed triptans. So this is where we start talking about a tailored approach to migraine acute treatment, because sometimes triptans are contraindicated due to cardiovascular risk profile, and NSAIDs may be contraindicated due to ulcer or GI upset or GI intolerance or due to asthma, etc. Because sometimes if we switch between triptans, we may not have added value. And usually we do one switch. So we let the patient try 2 triptans before we say that triptans are ineffective. At least this was our practice until the era of Japan's. And concerning the disease burden, these unmet needs in the migraine, mainly now in the acute treatment of migraine, lead us to reflect on the disease burden, as I said, first as on the social level, and then on the economic level, and then as a public health and emotional level. On the public health level, 70% of the migraineurs believe that migraine affects professional life. In average, they would miss 4.6 days of work each month. That means more than 1 day per week, and this is a huge loss of productivity. 13% would report reducing the number of hours worked due to migraine, and up to 1/3 agree they would be more successful in their career if they did not have migraine. So from here emerge the 2 concepts of presenteeism and absenteeism that we evoke a lot regarding migraine. Absenteeism being work hours or work days being lost due to migraine. And this is related to the disability and inability to perform. And presenteeism being present for the patients who have mild to moderate headache, who are able to reach their workplace, but never able to perform on an optimal level. And this would be also work hours of productivity lost. Migraine also affects the social relationship and the social networking. We all know a friend or a colleague that would miss a lunch or a party or a family reunion because they are having a severe headache and they cannot attend. 16 to 18% report canceled or missed events once per year. 14 to 30% report that migraine significantly impacts their relationship with their spouse. Not to forget the financial impact, with all the money spent on co-payments for ER visits, for clinician visits, for over-the-counter medications, etc. So usually the targets of treatment in migraine differ whether it is a preventive treatment or acute treatment. The preventive treatment usually has a target of reducing the frequency of headache, so reducing the monthly migraine days. And this is the headache diary that we all give to our patients to track their response to the preventive treatment. And usually a successful preventive treatment would ensure 50% reduction in MMD and up to 75% reduction in MMD. And then we would expect an efficient preventive treatment to also reduce the intensity of headache. And this is what we promise the patients, that they will have at least half their migraines gone with an intensity much milder, from moderate to severe to mild to moderate headaches. And this will allow us to gain in terms of regain of function, to decrease in disability and decrease in overall cost. Regarding acute and abortive treatment, the goals are different. The goals are rapid and consistent freedom of pain and associated symptoms that we call most bothering symptoms without recurrence. We do not want a treatment that, for example, like a lot of NSAIDs in a severe migraine would offer pain relief for an hour or two, and then the migraine is back again and the nightmare is back again. we would want a restored ability to function, minimal need for repeat dosing or rescue medications, because here lies the danger of patients taking a lot of medications and making their cocktail of their own over-the-counter medications, of association of NSAIDs, muscle relaxant, painkillers, triptans, and sometimes repeating the doses of triptans with huge implications on side effects and medication overuse headache. Optimal self-care and reduced subsequent use of resources, which would be emergency room visits, diagnostic imaging, etc. And then by controlling the acute treatment, not only the preventive treatment, we would also reduce costs, minimal or no side effect, and cost considerations. So there comes the era of GEPANs. Up till now, since I was a Med 1 student, we only had triptans, and this was our tragedy. So now there is the era of GEPANs, and we are the lucky clinicians accompanying this era. So as we all know, CGRP is highly implicated in the pathophysiology of migraine, be it in the trigeminovascular activation and the resulting vasodilation. And usually the vasodilation is the main basis for the throbbing nature of the headache, or also be it in the sensitization of the CNS sensitization and CGRP-mediated pain transmission. So it would be very interesting to target CGRP in acute treatments as well as in preventive treatments like the monoclonal antibodies would do. So the ubrogepant binds to the CGRP receptor with a high affinity, and then it would inhibit binding the natural CGRP ligand, thereby preventing downstream effects, including vasodilation and CGRP-mediated pain transmission. But the interesting fact is that although CGRP is a vasodilator or induces vasodilation around in the meningeal vessels, when ubrogepant inhibits CGRP, it does not cause the reverse side of vasoconstriction. And this is where it is interesting by not being unsafe for cardiovascular patients. And that's why it is safe for this kind of population. The main studies that showed both ubrogepant efficacy and safety are mainly the ACHIEVE-1 and ACHIEVE-2 studies. The design was made in ACHIEVE-1 between placebo, second arm ubrogepant 50 milligram, third arm ubrogepant 100. And the ACHIEVE-2 randomized patient into an arm of placebo, a second of ubrogepant 25, and a third arm of ubrogepant 50. Ubrogepant 25 milligram did not show any significant difference in efficacy from placebo, so it was not it did not have the acceptance for marketing. So the long-term safety study randomized patients from these two to usual care, the placebo, ubrogepant 50 milligram or ubrogepant 100. And we also had the dedicated liver safety study with ubrogepant 100 milligram, 28 and 56 days. So what are the outcomes? The first co-primary efficacy endpoint was pain freedom at 2 hours post-dose. And when we say pain freedom, it's zero pain. So the patient is pain-free. The patient is having moderate to severe headache. Next slide, please. And 2 hours after the dose of ubrogepant 50 milligram, or 100, he would be strictly pain-free, and the sky is blue again. I know this is a lot to ask from ibrogepant, and I would call this study overachieve, not achieve, because usually it's a lot to ask from an acute medication to achieve pain freedom, starting from a moderate to severe migraine in just 2 hours. Despite this, we reached 19% of pain relief in patients who took ibrogepant 50 milligram, and 21.2% in patients who took 100 milligram, with a significant p-value versus placebo. And this data was also proven in ACHIEVE-2, where the patients who took ibrogepant 50 achieved pain freedom at 2 hours post-dose in 22% of the cases. And this was also reproduced not only in freedom of pain, but also freedom of the most bothering symptoms, because sometimes the patient would say, well, my headache is gone, but I still have the nausea and I can't function normally. I can't spend my day normally. So there is the pain and there is the most bothering accompanying symptom of the migraine, which is usually nausea or photophobia or phonophobia, etc. So also the ACHIEVE-1 and 2 study showed that in up to 40% of patients, there was absence of most bothering symptom at 2 hours post-dose. And this was highly comparable in ibrogepant 100 milligram, and it was reproduced in the ACHIEVE-2 with also up to 40% absence, 40% of patients that reached absence of most bothering symptoms at 2 hours post-dose. Next one, please. So then we asked ourselves, maybe it would be interesting to ask something more real world from the ibrogepant. And then we asked for secondary outcome that would be pain relief and not pain-free. Pain relief, meaning what we usually promise the patient when prescribing a prophylactic or preventive treatment, that their migraine would shift from being moderate to severe to being mild to moderate. So maybe this gain in pain intensity would allow them to regain functionality, to regain work, to regain an acceptable quality of life in the subsequent hours or days after migraine. So pain relief at 2 hours now was achieved in up to 60% of patients, not 40% as the previous slide, with ibrogepant 50 milligram, and comparable percentage with ibrogepant 100 milligram. Sustained pain relief after 2 hours until 24 hours was also reached in more than 1/3 of the patients, and sustained pain freedom up to 24 hours was reached in 12% and 15% of the patients respectively with ibrogepant 50 and 100. And these results were also comparable in ACHIEVE-2 study. When we go into the various most bothering symptoms, in each of the MBS, we found a comparable, a reproducible result. Absence of photophobia at 2 hours, 40% to 45% of patients with ibrogepant 50 and 100 respectively. Absence of photophobia, phonophobia, up to 57 and 55% respectively, and absence of nausea at 2 hours up to 70% in both doses of ibrogepant, with reproducible results in ACHIEVE-2. So till now we spoke about the pain relief, the pain freedom and sustained pain freedom. And for the sustained pain relief, at least for the patients who cannot achieve the pain-free results, there is a promised sustained pain relief in up to 1/3 of the patients that took ibrogepant 50 milligram up to 48 hours. And for ibrogepant 100 milligram, up to 35%. So as we said, when we achieve optimal control of pain, we will achieve a regain of function and decrease in disability. And these are the percentages of patients that regained normal function after few hours of their first ibrogepant dose, with up to 78% of patients reaching normal function 8 hours after their first ibrogepant dose. And this was also reproduced in the ACHIEVE study, ACHIEVE 2. So this is, as we said, I need you to focus with me. So up to 78% of patients reached normal functioning level 8 hours after their first dose. Next, please. Next one. So after proving the efficacy, we should look into the tolerability profile and the safety profile of the ibrogepant. As I said earlier, that ibrogepant interestingly inhibits CGRP without causing the other sides of the coin, that would be the vasoconstriction. And then one would expect that this is a safe medication for high-risk cardiovascular patients. And this is what we tried to prove in the ACHIEVE 1 and 2 pooled study. So we categorized patients into moderate to high cardiovascular risk, low risk, or no cardiovascular risk factor. Concerning the serious adverse event, there was none in all arms of study. And concerning the treatment-related adverse events, there was no significant difference between the ibrogepant, whether be it 50 or 100 versus placebo. Next, please. So one would ask now why there are 2 doses of ibrogepant. Why there is the ibrogepant 50 and why there is the ibrogepant 100, and when to prescribe each dose. So this study showed that there is an efficacy of the optional second dose. For example, for the 19% of patients that reach 2 hours pain freedom, if they took a second dose, this percentage had risen until 35%. And for the patient who achieved first dose pain relief, there was also increase in the pain relief when another dose of ibrogepant is taken. So we can say that for patients that did not take the optimal effect with the first dose of ibrogepant, for example, their headache went from severe headache to moderate headache, but they still want a better control of their migraine, there is an option of an additional dose that would achieve better control. And also for the overall population, which who wanted to achieve the pain freedom, there is also the second dose option that would increase the proportion of pain freedom. Next, please. What are the side effects? The main side effects that we saw with ibrogepant were nausea, dizziness, somnolence, dry mouth, and fatigue. And interestingly, they weren't much more frequent than in the placebo arm. And then if I want to close the loop with the beginning of my talk, when we spoke about the prodrome phase of headache, next slide, please. So this is where it gets interesting, because we tried to study the prodromal phase of the migraine headache in order to try to prevent the subsequent migraine. And this was a very interesting concept and a genius concept in this study, where patients were screened for their prodrome qualifying events. And we asked patients what were their prodrome symptoms that would be followed by migraine in more than 75% of the cases. And then we randomized them into first prodrome event taking placebo, second taking ibrogepant 100, or vice versa. Next, please. What were the prodromal event? The most frequent prodromal event was sensitivity to light or photophobia. Then came fatigue, neck pain, sensitivity to sound, or dizziness. Again, these are symptoms that patient reported being followed in the next few hours, next 6 hours mainly, by a migraine in more than 75% of cases. Next slide, please. How they were distributed. It was a fair distribution like the natural distribution in migraine. For example, for photophobia, 60% of patients having prodrome photophobia would have a mild migraine, 32% moderate migraine, and 7.2% severe migraine. And same goes on for the other prodromal symptoms. Next slide, please. And then these are the results. Up to 45% of patients achieved pain freedom 24 hours post-dose after a few hours later than the first prodromal event. And this was after taking the ibrogepant 100 milligram. And also 40% of patients achieved pain freedom up to 48 hours post-dose. These data are very interesting for me in the terms of mini prophylaxis, because usually we have patients that have situational migraine. So they would say, my migraine is controlled, but I still have migraine during the menstruation, for example, or I still have migraine when I travel and I have jet lag. So this prodrome study allows us to halt the progression into a migraine headache from the prodromal symptoms. And then we would counsel patients, for example, to take the ibrogepant 100 milligram at the beginning of their menstrual period, for example, or on the day they travel, for example. And this would allow us a mini prophylaxis or a very short-term prophylaxis for situational migraines. And I think this is very interesting, and I usually apply it with my patient, and it works very well. So these are the data I wanted to share with you, and I'm happy to receive your questions.
So thank you, Dr. Kalien, for introducing for us this very effective and tolerable anti-CGRP. So we have many questions actually for you, so please bear with us. So the first question, if a patient fail on one Japan, do you recommend to shift to another Japan?
Up till now, our experience with Japan is very satisfactory, and we didn't have to shift between Japan up till now. But there is interest sometimes in shifting between Japan, because the two available Japan currently in the market have different half-lives and different time to peak concentrations. For example, the Rimegepant is more in the middle concerning the time to peak and the half-life, and that's why it works both, or it is approved both for acute treatment and preventive treatment, whereas the Ubrogepant has a T half-life that is shorter and time to peak that is shorter, and that's why it is approved as an acute medication. So sometimes the tailored approach to a patient would be shifting towards one than another. But this is in terms of tailored approach, but not in terms of failure of one of the medications.
What is the drug of choice for a pregnant woman who is experiencing a migraine attack? How do you treat her?
Up till now, we are not, the Gepan are not indicated for pregnant women. And even when you prescribe Rimegepan as prophylactic treatment, we would recommend stopping it and when pregnancy is planned. The monoclonal antibodies in preventive treatment also are contraindicated. Most of the preventive treatment, the standard of care, are contraindicated, except the amitriptyline. The amitriptyline in the European references is accepted for pregnant patients, and I specify European references because for other references it may not be accepted. But for the CRAT, for the Center of Reference of Teratogenic Agents for Europe, amitriptyline is approved in pregnancy. For the acute treatments, until now, to be on the safe side, the only approved acute treatment is paracetamol or NSAIDs according to the term of pregnancy if the OBGYN permits it.
And since we are talking about women, I have another question related to menopausal stage. So does menopause trigger migraine attack? Do we have any association between menopause and increase in the frequency or decrease in the...
Congratulate my patients when they reach menopause. Because in fact, they reach a steady state of hormone, and sometimes menopause relieves migraine in a high proportion of patients. But it is the perimenopausal period that is subject to high fluctuations of hormones that may worsen the migraine or trigger it again after periods of migraine-free periods.
Another question.
So we should focus on the fluctuations of hormones. For example, that's why in pregnancy during the first trimester, migraine may be worse, etc. But usually when hormones reach a steady state, migraines are better. And the menstruation, the menstrual or the catamenial migraine is usually due to a acute drop in hormones and not due to the hormones themselves.
Another question, Dr. Khalien, can we use the same anti-CGRP as abortive treatment and preventative treatment in the same patient?
Yes, as I previously specified, for example, the Rimegepan, because of altered pharmacodynamic differences between Ubrogepant and Rimegepan. Rimegepan can be accepted both ways as an abortive and a preventive treatment. But the prodrome study of the Ubrogepant allows us to use it sometimes for situational migraines that would be a mini prophylaxis and not as a preventive migraine because it is not approved as a preventive migraine. But for example, for situational migraines, we can use it ahead of the headache and then halt the progression of prodrome into a migraine, and then it would act like a mini prophylaxis but not as a legitimate preventive treatment.
The final two questions for you. I received more than 5 questions asking about the role of magnesium. So can you elaborate on magnesium supplement use for prevention and treatment of migraine?
Magnesium supplements can help, but they are not the mainstay of treatment. That's why sometimes when we are helpless during pregnancy, we may prescribe magnesium supplementation because they may help controlling migraines, but they are not the mainstay of treatment.
And how would you treat a patient with concomitant generalized epilepsy disease? So how would you treat if he has generalized epilepsy and migraine? Would this seizure activity affect the choice of treatment?
There is a relation, and there is increased incidence of these two disorders together. Usually, the standard medications that we have till now did not show to increase the risk of epilepsy, but further studies are needed on this.
And the final question, can genetic... Yeah, Joelle, sorry, apologies.
I have a question for Dr. Kelly.
Yeah, sure. Go ahead.
Hi.
Hi.
So in practice, are you using more Abrogepant as the 50 milligram dose or the 100 milligram dose for your patients?
Usually, because the patient don't like, they like to be given options, but they like to be put into a frame also. So usually there is like a rule of thumb: the patient that have been having triptans, is having headaches that are unresponsive to triptans, is having 1 or 2 preventive treatments, etc. For this patient, I would go right away to the Ubrogepant 100. Yeah. But for a naive patient who didn't try the triptans or is on one chronic medication and is controlled but needs better control for acute medication, then I would offer the 50 milligram with an optional option of supplementary dose, because sometimes patient would be anxious. What happens if it doesn't work? Because we would give them usually 2 options. One option of NSAID or paracetamol or that is for the mild headache, for the acute control of mild headaches. And we tell them, when you have the moderate or severe headache, you would go for the Ubrogepant, because the ACHIEVE trial is overachieved trial. So that's why that's where they would get anxious, and then they would say, what if the other treatment also doesn't work? So it relieves them to know that there is the additional dosing option.
Right. Okay.
A final question for you, doctor. Can genetic influence a person's susceptibility to migraine and migraine attacks?
Sure, there is a high genetic susceptibility, and usually a lot of patients, of migraine patients that we see, have their sister or their mother affected by migraine. I'm saying sister or mother because usually it is a disease that affects women more than men in a ratio of 2 to 1. So there is a high genetic predisposition, but again, it's not destiny. We can have a family of migraineur and not become a migraineur ourselves. So I don't like people to stress on the genetic predisposition. I'd like them to stress on lifestyle modification whenever they have a migraineur in family. This would be their chance to embrace healthier lifestyle and to prevent or delay migraine as long as they can.
Thank you, Dr. Kalin. Those were all the questions from our attendee. Thank you for being an excellent speaker tonight and for joining us and staying with us late tonight. Thank you so much. I would like to ask all our attendees to scan this barcode and fill the post-event evaluation. Also, I would like to remind you that you will receive your certificate of attendance by email within 10 days from tonight. And also, if you missed any of the lectures, or if you would like to revisit the presentations of our experts, you can visit our IVPN library, where we post the recordings of all our webinar. And currently our library can be accessed free of charge. So you can just visit our website and visit and choose the webinar you would like to re-attend and watch the lectures and access the lectures. Also, I would like to invite you and encourage you to keep your eyes on our social media platform, mainly our LinkedIn IVPN NeuroPsychiatry page, and our social media platform, because we have more scheduled educational activity from now until the end of this year. And stay tuned for our next edition of this Multidisciplinary Migraine Summit, which is scheduled on October 9. So save the date for October 9. And thank you for Dr. Colleen for highlighting the fact that migraine is more common in women and men. That's why in our second episode, we will host a gynecologist who will discuss more migraine from menstruation to pregnancy. So save the date, October 9, don't forget, and stay tuned. Until I meet you again, stay safe and have a good night. And a final reminder for you to fill the post-event evaluation. And a big thank you for AbbVie for sponsoring this educational activity. Thank you very much for everybody. Thank you for our speaker, Joelle, Dr. Marlene, and Dr. Colleen for accepting our invitation. See you all very soon.